are running these models on at Reliance Foundation Hospital right now. Next slide. This is how the computer images look. So we're training the computer along with the gastrographic swallow images. We're merging them so that the accuracy rate starts improving more. Now this is unsupervised learning. The problem with unsupervised learning is that this unlabeled data. So I've just fed in all data. All comers with right iliac fossa pain, I've just fed in. So the accuracy of unsupervised data, unfortunately, is not like supervised data. And that is where technical things can happen. Alright, so I will not know which patient will bleed, which patient will not bleed, because again it is unstructured. Which surgeon is operating? What is the skill set? So the machine can't figure out. Machine is what you feed and what it learns from. So if you see that the accuracy rates will be a little lower here as compared to the supervised learning model. And the only reason is because this is not structured data that we fed. Again, the weaknesses are the evaluation of the model performance. There's other clustering methods, calculating the time of implementation of the proposed method. High error, non-design method, removing the noise of MRIs and various other things. So there's a lot of weaknesses in this as compared to the strengths of an unsupervised learning model. The other methods are something called as reinforcement and semi-supervised learning. Semi-supervised is where you put in the labeled data along with the unlabeled data. And what is reinforcement? Reinforcement is where you train the machines to learn through trial and error, take the best method. So let's say a machine has done something wrong, given you wrong data. Then you tell the machine that this was wrong, so it can recognize the right thing. So let's say a machine calls, you put 10 images of cats, and suddenly put an image of a dog, and the machine calls it a cat again. You have to tell the machine that it's judged wrong. Alright, sometimes the machine can get confused by different images. Sorry, I keep forgetting things. I should act like a robo, right? So, if you look at the reinforcement learning model, again, if you look at the accuracy through virtual ring therapy is around 100%, right? Because it has got, you've taught the machine again and again of where it's gone wrong and where it can go right. Again, the weaknesses are it's not explaining the simulation tool, so insufficient experiments to evaluate the final model, not considering a suitable pre-processing scheme. Insufficient experiments to evaluate the final model, not considering a suitable pre-processing scheme, not considering different parameters such as sex, age. So if you've not fed in the right parameters, sometimes you might not get to the right point. And that's probably the weakness of these reinforcement learning models. I'm just trying to touch on these very few terms so that I won't try to bore you too much with technical stuff, but you should at least know all this because this is going to be the future. This is going to be what you are going to be practicing. This is semi-supervised learning model. Again, accuracy rates all drop as compared to a supervised. So we're trying to figure out whatever is the best method to try and more data again always helps. Now, what is NLP? NLP is natural language processing. So when we speak, like in the OR, if I speak and record a surgery, the exact notes that I'm recording, if I continuously do it 10 times, 100 times, the machine starts recognizing those words, right? So if I use, let's say, CA breast, next I call it malignancy, next I call it oncosurgery. Machine cannot figure out, but 100 times I do this, it will start recognizing that a cancer is the same thing as a malignancy. Right? They're different words, but they mean the same thing. If I confuse it with stage 1 to stage 3, it will start figuring out what is stage 1, what is stage 3. And that is where NLP comes in. So NLP is today what Google and Microsoft and all are doing. That's where they make their billions, right, in learning. So today if you want to, say, speak in Arabic, right, we go to Google Translate and we put in certain words. And because it's learned over, now who's taught the machine is important because sometimes it gives us completely different connotations of what we are trying to do. If you put something in Hindi, it sounds really funny if you put in an English translation, right? So it's not perfect, but we're trying to get our act perfect. So NLP is basically natural language processing, and that's what it is. For example, if I were to do it in surgery, all right, and automatically comb through all the EMRs that we are putting in tons and tons of data on. It was able to adjust predictive weights for phrases describing the patient. Like, let's say a patient was irritated or tired relative to the post-operative day when it predicts leak. The sensitivity is 100% or the specificity is 72%. So it's about a colonic leak versus a patient just feeling tired. When you teach the machine, it can start predicting these kind of things. Things like anastomotic leak, deep vein thrombosis, myocardial infarction, pulmonary embolism are all being investigated as we speak. What can predict or what can prevent these catastrophic complications that happen post-surgery? You had a knee replacement or you had a bariatric surgery, suddenly you found the patient dead because of a pulmonary embolism. That's not acceptable to either the patient or the relatives. So that's why we can change a lot of these things. Now, what is artificial neural networks? Well, basically this is how our brain works. Exactly like how our brain works, the computer works. On various inputs and outputs and multiple layers, and it works like a super fast computer. Our brain works like that. So we are trying to match that by doing these various things. So what these neural networks basically do is these algorithms are put in, and this is skin images. Now when they put skin images of a lesion, let's say, and they taught the machine, the algorithm was trained over 1.5 lakh, let's say, labeled pictures of 2032 different diseases. And what they did is they had a biopsy which was proven that was belonging to a certain thing. Whether it was malignant melanoma or benign lesions. And this machine predicted to the accuracy which was far superior to 21 board certified dermatologists. So it predicted better than the board certified dermatologists, right? So this is how robotic training is going to happen. This is real time and this is happening now. One second, gone back. I just wanted to show that. Yeah, can you play this video? This is how training is done now. So you don't need to actually practice on humans, but this is the Oculus 3 where they are practicing knee replacements, let's say. It gives you the exact depth, the exact feel of what that surgeon has to do. It gives you the error. And this is all he is doing. He's standing on a space with these VR glasses and doing the same thing. Okay. Now if he wants to operate on the spine, the entire 3D image of the spine is picked up and then he can operate on the spine. This is his supervisor who is supervising what this guy is doing, tell him whether he's doing the right thing or the wrong thing. He can put retractors himself and retract things. It's almost like a 3D image around you. And now you just see an image of how doctors look when they're practicing, right? So this is how the labs are set up. So you're actually feeling how you're going to operate. This is what they are. They're actually operating. They're doing a knee replacement. You might think they're zombies, but actually these are surgeons going out and practicing without any bloodshed. So they're not going to damage any human being while doing this. Yeah, so even suturing, everything, and I can grade these students without anything. Within a matter of seconds, I can grade all of these students and do. This is laparoscopy, knee arthroscopy, and what they've realized is that the surgeons who were trained on VR actually did far better when they've actually put on the human than people who went directly on humans. And this is what training is going to become. So when you get into surgery, 5 years later, don't be surprised if someone tells you to wear these AR. Don't play games that time, but please actually go out and do the right thing. So it's all there. I actually forgot to put a video of mine, which I couldn't put in, of me actually doing it. I've done it myself. And my son thought I was completely like a zombie. So that was a weird thing. Just standing out. You have to mark your space so you don't go and damage anything. Oculus 2 is the new setup. I think it's for around 30,000 bucks. You can play games, you can do a lot of things, you can actually practice surgery as well and how we do it. So, artificial intelligence surgery should be used for pre-operative planning. What do we need is accuracy, automation and speed. Alright? The challenges are that there's a lot of multimodal inputs. So, you'll have inputs from the anesthesiologist, you'll have inputs from the lab, you'll have your own clinical inputs, you'll have X-ray images, every other thing. there might be a patient who might be septic, so you'll have to change the way you want to do these things, and depend on diagnostic data and various other things. And then anatomical classification, are you operating on the brain, the heart, the kidneys, the lungs, the liver, what? So these are the challenges and sub areas of AI that need to be used. But when you put all this kind of data onto that, all right, and then there is a risk algorithm, it will actually tell you in your particular hands what is the risk of this surgery going right or going wrong, given that particular patient's age and everything. So you will know the outcomes. For your colleague, it might go better or worse because his skill sets might be completely different from what your skill sets are. For a septic patient, it might be much worse outcomes. For non-septic patients, it might be different outcomes.
In this,
so this is, for example, how anastomosis is being done right now, and this is done at Johns Hopkins Institute, and how they do anastomosis to figure out whether the anastomosis can be, you can play the video. This is called STARS.
in this video, we demonstrate enhanced autonomous laparoscopic anastomosis of the small bowel using the smart tissue autonomous robot. Small bowel anastomosis is a procedure performed over a million times using manual, laparoscopic, or robotic techniques. During this task, the surgeon stages and reconnects two loops of bowel by suturing adjacent tissues using either running or interrupted stitch. Consistency of these stitches is critical for successful anastomosis, as even a single missed stitch can result in leak with catastrophic complications. Autonomous robotic suturing can complete this task with more consistency and repeatability than that of an expert surgeon. The automation of such a complex and delicate task required the development of many innovations. These include the adaptation of surgical tools to robotic platforms, the combination of near-infrared and structured light cameras for three-dimensional imaging, and robotic control schemes that generate surgical plans to autonomously correct for tissue deformation and obstruction. We now showcase these innovations by performing a small bowel anastomosis using the smart tissue autonomous robot. A loop of small bowel is first detached from the surrounding tissue. Using manual technique, a surgeon applies a transverse cut to separate the bowel into equal halves. Transabdominal stay sutures are placed in the right and left corners of the bowel. These sutures reapproximate and align the two halves of tissue in preparation for the anastomosis. The same stay sutures are then passed through the abdominal wall so tension can be adjusted from outside the patient. A third stay suture is placed on the front wall of the bowel and used to open the anastomosis. Near-infrared markers are then manually applied to the corners of the bowel for robust tissue tracking. As seen, STAR's imaging system detects and tracks the anastomosis site, despite soft tissue deformations and breathing artifacts. Furthermore, STAR generates three-dimensional point clouds of the surgical site and autonomously overlays optimized surgical plans for the anastomosis. When a surgical plan is not consistent with the three-dimensional point cloud as shown on the front wall of this tissue, the surgeon initiates a replanning algorithm to generate a new point cloud with corresponding surgical plan. STAR creates an anastomosis by first performing a running suture along the back wall of the small bowel. A human assistant removes all loose thread from the surgical field to prevent the formation of locking sutures during the anastomosis. Similarly, STAR completes the second half of the anastomosis by using a running stitch to close the front wall. Sutures are applied with uniform spacing as determined in the initial surgical plan, while robust tracking is enabled by the near-infrared imaging system. At the end of the surgery, the anastomosis is manually inspected for missed stitches and defects.
So this is, the human is the assistant, and the robot is actually the operating surgeon, and that's what they've achieved, and this is actually been done.
In this video.
So the limitations are that today our biggest problem is our data is very limited. We've still not got enough data to predict every other disease that there is. But for all naysayers who say that artificial intelligence will never come into healthcare, well, they are already archaic. Okay, it's like technology, right? So it's like the road and the road roller. You either be part of the road or the road roller. You have to decide which way you want to be. And this technology is here. It's here to stay. So the problem is that there are both costs and risks to utilizing ML, machine learning models, incorrectly. So if you don't do it correctly, you don't blame the machine. It's just that you've not given the right inputs to the machine to learn accurately. despite advances in causal interference, AI cannot yet determine causal relationships in data at a level necessary for clinical implementation, nor can it provide an automatic clinical interpretation of its analysis. So we are still maybe, I can say, 10 years away from letting AI run our lives, but it will come as more and more data is calculated accurately. So what are the future applications of AI? A future surgeon will likely see AI analysis of population or patient-specific data augmented each phase of care, right? So when in a whole of India, someone in, let's say, Maharashtra might be treated completely different from someone in Kerala, or someone in Assam, or someone in Punjab. There might be completely different ways of treating, or it might be the similar way of treating the same disease. Preoperatively, a patient undergoing evaluation for, let's say, for example, pediatric surgery, there might be tracking of his weight, his glucose, meals, activity, through mobile application fitness trackers, with data feeding into the MRI, and the automated analysis of all the preoperative mobile and clinical data to provide patient-specific risk score of which surgery to be planned on that particular patient and which would do best. There are various types of surgery. The next is the surgeon could then augment the decision making intraoperatively based on real-time analysis of maybe the robotic surgery that he does, and to prevent the post-op complications. Then the integration of pre, intra, and post-operative data could help monitor recovery and predict complications for a particular patient. So you become more and more like how financial analysts predict the chance of rain, for example, or the chance of markets crashing. All that will happen in a patient. You'll have a high predictability quotient where you'll be able to tell a patient whether he'll survive, he'll not survive given the disease that he does have. And you will become more predictive in your method of treating people. Just imagine putting in all this kind of preoperative comprehensive risk score, intra-op event detection and predictive analysis, and post-op management all into one, and then telling a patient, well, when he walks out, this is the percentage of you doing well with this particular operation. That's going to become a reality in the next 5 to 10 years as we speak. So preoperative planning, intraoperative guidance, surgical robotic techniques of robotic surgery. The only thing is ethical and legal issues surrounding it. So today it seems far-fetched, but who would have thought that you probably carried your entire dictionary of friends, enemies, and whoever else you wanted within your pocket in a phone. When Steve Jobs thought of it, most people thought he was crazy. But today that's a reality, and we carry our entire life on our phone. So most people who actually don't want to be reached out at all don't carry the smartphones any longer. So we're going retrogressing because when we don't want to be contacted. So people, otherwise every app that you've got on your device is tracing and getting data out of you on a single minute. Thank you so much. This is something I wanted to tell you all about, the future of where we will go, so that you all at least helps you all open up the eyes of where the next generation of surgeons will come from and what you will do. I just want to tell you that I probably am going to study data science and applied digital health in Oxford next year. So I'm going to take a little break from surgery. You won't see me wearing surgical scrubs, but you'll probably see me wearing one of the weird things and start playing around. But yeah, I think look at digital healthcare as another field that you all should look at, because that will come with me here to stay. And the engineers who do data science, who do artificial intelligence, don't really have the answers that doctors have. So they will need your brain, they will need your vision, they will need your guidance to try and get these models right. Thank you so much, and thank you for inviting me.
Anybody who wants to ask sir any questions, you have this golden opportunity, you can go for it. Any questions at all? Yeah. that was an amazing session. According to you, how should the medical professional and the current and the future doctors should work to take these technologies to the rural areas, because that's where we need better medical facilities?
I think first and foremost, we should not close our eyes to modern technology. And another thing we should do is we should adapt to electronic medical record, data collecting. We should put in ICD-11 scores, because ICD-11 is now available, because every single data that we collect on any particular patient is going to land up helping the patients eventually. So all I can tell you is, when I was taught surgery and I was taught medicine, there was no concepts of EMRs, right? Today we as doctors find EMRs very cumbersome, because you have to keep entering a lot of that data. But all that data is getting recorded somewhere. That's helping a human being. And like I said, as many number of doctors we do produce, you will never be able to bridge that gap between rural and urban healthcare. Today, your top doctors are always going to be practicing in urban India. Your tertiary hospitals and quaternary hospitals are going to be in urban India. But there are lives meant to be saved in rural and tribal India. And that's where you can make a difference. You know, I go for these charity camps to Rajasthan interiors, to Maharashtra interiors, Gadchiroli. I just went for a camp. I'll be going one in August again. And I just know how much that divide is. We think it's very simple to say, within the golden hour, to prevent someone from getting a stroke and surviving and not getting too big a deficit, or saving him when he gets a heart attack. But in rural India, they can't even diagnose, because there are no doctors that diagnose. So the moment I can put in one drop of his blood and get a drop T, I can get an ECG tracing on him, which any technician can do, even the local worker can do it. On the machine, which he can wear a smartwatch, and that can give him blood sugar, tracings can be done, and there can be an artificial intelligence algorithm which is sitting there, which can predict if this guy's got a stroke or a heart attack. Someone out there can give him medication that might actually allow him to reach the urban place and save his life. That's where I think the gap will address.
Thank you for the session, sir. Sir, the use of artificial intelligence, to what degree does that count as replacement of veteran doctors?
Doctors can never get replaced. How many ever there will be for us. But we will use our time far better. We will use it far better. For example, you don't need, if you become a radiologist today, you don't need to waste your time trying to figure out whether an X-ray image is normal, right? If there's a 99.9% predictive analysis that there's an X-ray image which is normal, you don't need to waste your time. You'd rather figure out your time on doing interventional radiology. You might rather figure out your time on figuring out complex things which a machine can't yet read, and saying, this CT or this X-ray, there is confusion, so let me figure out and let me spend more time on this one X-ray. Today, when you have 200 patients to see, usually it's not possible to look at all 200 patients in the same length of time. So let's say I remove 150 of those X-rays and tell you to look at only 50 X-rays. You're going to do a far better job looking at those 50 X-rays. That's where it should come.
Thank you.
Thank you. It was a very good session. In pathology, artificial intelligence has taken a leap. But what I feel is it cannot replace a doctor, because they need somebody to be accountable for a particular report. So no matter how many reports are generated, and even if a histopathology is interpreted using artificial intelligence, the surgeon would still require a pathologist to sign it out and take onus of whatever has been reported. What do you have to say on that? Do you agree to that?
And that's where the medical, legal, ethical issues come in, right? Today we are not right there. So we are not ready for prime time with artificial intelligence. But yes, our accuracy is getting better and better. Let's say today we've got 100 images to predict that pathology report. Tomorrow you will have 1 lakh images to predict. Then your accuracy will become so certified that the actual pathologist will probably sit at home, have the computer run all these images, run the diagnosis, rule out the differential, give him 2 differentials for what he's looking at. And he'd be pretty sure that the computer is saying the right thing, because the computer's gone through billions of images already and looked at the same thing. So I think where we will be is utilizing our time to the most effective thing.
And tell me, how effective would it be to put up artificial intelligence as far as the cost of it going into it comes into?
Right now, it's really, like I said, it's not ready for prime time. This is all meant for research. This is the future. This is 10 years down, but it is here to stay. If it's like laparoscopy, right? So I had my teachers who would say, I make so much of a mini laparotomy. If you join your 4 incisions, it amounts to the same thing. That's not great. Surgery has changed. Robotics, when it came and people said, why do robotics? It's expensive, it's this. But the world is going to change that way. The world is going to say, demand something more. So I think when it comes to accuracy, everything will change. But we are yet not there. We are yet not certain. And when we deal with the human life, there's emotions involved as well. And that is where we have to think, can I sign off something without action? How sure am I of the machine or the robot? When we fly a plane, we don't doubt that, right? We never actually ask your computer, do you think this is my friend's phone? Do I double check the number? I don't. Today's become a norm. Do you actually question Google? I've come here with Google. I never question Google that, are you taking me to the right place or not? So in 5 to 10 years, we will come to that stage where doctors will accept what is being told to them because it's been certified and recertified time and again. And I think where we use this time for our families.
Would it be financially viable?
It will become.
It will.
Not now. Like I said, human genome testing today is 1.5 to 2 lakhs. Later it will become $100. If it becomes $100, everyone's going to say, rather than going out for a meal, I might as well do my human genome analysis, which is accurate. So the idea of technology, like GPS was meant for the US military until it was opened up. And today, we can't live our life without GPS, right? So that is how technology is. Technology is here to stay. We just have to accept it. To what extent right now? I'm telling you it's not ready for prime time. So if today you tell me, can I trust the computer if it tells me this is acute pancreatitis or not? I can't. Because I'm not sure. Because my data set is still very limited. It's like semi-learning model today. It's not supervised learning model. But the moment there are 1 lakh images which all say the same thing, then it will become supervised learning. That's when your accuracy will become 100%. And then you yourself will start trusting the computer.
Just a little personal note. I had met sir when I was just 14 years old, and sir asked me like a very common question, what do you want to be? So I said I wanted to be a doctor, and 30 minutes after that I knew why I wanted to be a doctor. So sir is my role model. My hands are cold as I speak. He's not only inspired me, with an hour of sir's lecture, I'm sure all of us are deeply motivated, and thank you sir for getting us out of our textbooks, and when we step into the real world 10 years later, we know exactly what we're getting into. So thank you so much.
So that is one thing artificial intelligence can't replace, right? The connection and the impact you leave on us and on people. So that is something AI will not replace, but yes, AI is here to stay, as we've learned. Thank you so much, sir.
Just a little token of love from our academic heads and our CS sir for you.
Come on guys, you can be louder. The last applause for today. Come on, you guys have done it. One last time, come on. Thank you so much, sir. Requesting the OC to come on stage, the organizing committee. We'll take a picture with sir together. A very big thank you to sir, to the organizing committee, and lastly to the audience. The audience, give yourselves a big round of applause for being patient, being interactive, being alert, and for controlling your bladders as well. We'll see you guys tomorrow for the workshops and for the competitions. I hope many of you guys are participating. That's it for the day. Thank you.
Everyone, yeah, please, just the students. We just want to take a quick count of you all. Just the attendance, yeah, and then you all leave.
Batch, please give attendance to me.
All the volunteers who are going to stay for tomorrow for June, stay here. We'll be briefing you for tomorrow. Okay? Paper posted in case only. Others you need your slides.